All right, we're about 4 minutes after the hour. I think we can probably go ahead and get started. We might have a few people here join us as we continue in. But thanks everybody for joining, both from the roundtable side, the physicians, physician liaisons, and then also Cerner for joining as well. And just kind of level set, because I do know we have a couple new people who have not been to these roundtables before. My name is Brian Cottonsteady. I'm with Make Solutions, and we've been holding these CMIO roundtables for probably close to 18 months now. Dr. Halford was one of the original physicians that helped get this off the ground, and I also want to sincerely thank her for helping coordinate this with Cerner to make sure that we got all this together. But over the course of these different meetings that we've been holding, we primarily talk about physician-related items and things that are going well, things that we struggle with as organizations. And really, it's just an open forum for people to get together and talk freely and openly about the struggles that they have. One of the great things I think about this forum as well is we also share a lot of best practices and what we're doing to make things work and improve physician practices and experiences. A common theme that has come up at multiple discussions, though, has been around medication reconciliation. And so at one of our previous meetings, we took an entire hour and really kind of discussed what are some of the struggles that our individual sites are seeing with the medication reconciliation process. And I know these have been discussions that some of these individual sites have had with different groups at Cerner, but knowing sort of the force that this roundtable is starting to have with just getting everybody together, we thought this was important to just say, these are our 5 big items that all of these sites have agreed on as common struggles, and we just wanted to make sure that you had a chance to hear from us and respond to us, and just kind of tell us exactly where you are with some of your roadmaps, and that way we can have sort of an open dialogue. And I see we have some slides up here. We want Cerner, you to be able to give a chance to go through sort of what you're doing, but then also hear from the roundtable and the different physicians and resources that are on our side as well, and make sure you hear from us and some of the things that we have to say. So Dr. Kerschel, I don't know if you kind of wanted to kick it off there on your side with Cerner,
sure.
And we can go from there.
Absolutely. Thank you, Brian. And good afternoon, I guess, to most of you. My name is Dr. Walter Kerschel, and some of you probably know me. I'm one of the chief medical officers at Cerner and a senior director. And I've been working closely with Dr. Halford and the Covenant team, along with Dr. Sheth and also Francis Wu. And we, first and foremost, I really want to thank you all for the invitation, because I think this type of collaboration and partnership is what we need more of. I think within across healthcare, we want to be your partner. We want to listen. We want to understand where the end user struggles are. We want to understand what you're using as best practices and how we could help to communicate what we found to be best practices, talking to other clients around the country, and basically have a dialogue. So we're really excited about this. I hope we get invited back to other sessions. This is where I think the magic sauce is within the healthcare informatics community. The more we can collaborate, the better. So with me today, and I will let them introduce themselves, but we have Francis Wu, who is going to help us out with the med reconciliation process, as along with Dr. Sheth, who is one of our senior physician executives. And we also have Mike Reese, and he's one of our delivery partners who is engaged with Covenant very closely and has a lot of knowledge as well. So with that, Dr. Sheth, do you want to introduce yourself, and then Francis and Mike?
Sure. My name is Miguel Sheth. I'm a pediatrician, and as Walter said, a senior physician executive with Cerner. Been doing clinical informatics for 10 years and been engaged with Covenant for over a year, or about a year at this point. And so been looking through the MedRec issues and trying to help align some of the concerns with some of the responses from Cerner. Francis?
Yes, hello everyone. My name is Francis Wu. I have responsibilities for our strategy and product management team here at Cerner. So my team focuses on med-related solutions that includes the orders, MedsRec, ePrescribe, that side of things, along with the MAR and other med administration solutions and inpatient and outpatient pharmacy.
Thank you, Francis. Mike?
Yeah, good afternoon, Mike Reese, delivery partner. So aligned with Covenant Health and LifePoint out of Nashville. Spent a lot of time just focus on both operational and some of the clinical goals, making sure that we're delivering on our commitments and aligned toward those goals. So interface closely with Dr. Halford for Covenant and making sure that we're aligned. So appreciate everybody coming together. And like Dr. Kerschel said, I think these roundtables are an avenue for us to listen and understand and make sure that our roadmaps and the direction that we're taking the business are aligned with the feedback. So thank you.
Great. Thanks, Mike. Brian, do you want us to start off or do you want to do other introductions?
Well, we've got a number of folks on the call. Looks like we've got 5 or 7 organizations that are represented here. What I was thinking is just because I know we have a lot to get through.
Yep.
As we're going through this, if people want to sort of add their commentary or talk about the struggles that they're having with the particular items that we're going over, I would just say introduce yourself at that point in your organization. We can go from there. That way we can make sure that we're able to kind of get through this.
Great. All right, Brian. Well, thank you. Now, I'll turn it over to Francis here in a second, but we did not make a long slide presentation. I think Francis put together kind of one summary slide because we truly want this to be a conversation. So we're going to be informative. We're going to tell you our ideas, our thoughts, but we do want a conversation here. So feel free to interject, to give us your feedback, and we'll try to make this as interactive as possible. Francis, you want to take it over?
Yes, thank you. Okay. Let's see if I can get my slide to progress. There we go. So as Dr. Kerschel mentioned, we just put together this simple slide to reiterate those top 5 items that were previously discussed amongst your group and provided to us. And I put them in a particular sequence that does not match what was in the PDF to just kind of help us walk through the conversation. So you may notice that it doesn't line up exactly with what you see in the PDF. So we can sort of just start off on the conversation, and I will explain what my understanding is of the particular item. Definitely feel free to chime in if you have additional points of consideration that should be discussed, or if my interpretation is not exactly what was intended as your group previously discussed the different items. And then I'll share anything that we have within our current system or within our discussions internally that we may not have capabilities for at this time, but what our thought processes are around some of these items. So the first one that I have here is having compliance be visible within the medication reconciliation screen. That one was previously, I believe, number 5 within the PDF. That one, we do have compliance information that is viewable when you hover within MedsRec, and anything that is documented as not being compliant, we do show that within red text within medication reconciliation. Does anyone recall if there was additional conversation in regards to those capabilities being available, or if you think that red text was sort of the intent around that particular one?
I'm not sure if Clay is with us, but if I recall, this was a need, and I apologize, this is Dr. Mandy Halford, CMIO at Covenant Health. I believe that this was more of a need for outpatient clinics and really wanting to view that compliance within the ambulatory MedRec. Do others have comments to add?
And this is Tommy Patterson from Covenant Health also. Part of it is that we don't feel like the doctors are going to go looking for that information, but it's good to have it there face up so that they see it when it is available.
So I guess with that, Francis, it was more of how could we have an icon or something that visually lets you know compliance is documented without having to right click, go to the add modify compliance to see that information. So I don't know if those are items that you all have discussed or any plans for enhancements related to that.
I was thinking that maybe I would switch over. I do have an environment up.
Perfect.
Just to make sure that we all are sort of discussing the same thing. I apologize, this domain is not the fastest, but so within all of our reconciliation windows today, anytime that something is documented, so this list in April, for example, was documented as still taking, not as prescribed. So that information shows in red text face up within the medication reconciliation windows. So that would exist within admission reconciliation, discharge reconciliation, well, transfer as well. And then also on the outpatient reconciliation view that we have, you would be able to see that red text as well. And then when you hover over that medication, then you're able to see additional comments. So for this one, the comments were they're taking half a tab to save on cost, for example. Typically, if they're still taking it as they're supposed to, we don't show anything because we really don't need you to go hover on each one and look for more information. But we wanted to provide kind of that standard text up front, and then depending on the situation, you could hover and find out more information about that particular situation.
Thank you, Francis. I think that's all this request was, unless other CMIOs or other team members have additional questions. Now, remember, we put this list together last year, and so not everybody was on 2018 code at the time.
Okay.
And you know, I don't know if that is what accounts for the difference or not.
Yeah. And Dr. Halford and maybe Francis, you were going to show, but you're showing now that's the home medication component, which the compliance is also face up, so they can actually see that within that component as well now.
That's correct. Yep. And then that icon also indicates that there's additional information regarding that. So once you click on that row, then you can see the compliance comments from there as well. So in an ambulatory setting, they would typically, utilize this home medications view as that initial, landing spot for looking at the home medications. And then I'll sort of kind of jump into, future development that we are currently working on. It's not available at this time since we're talking about compliance already. We are working on making this compliance field a drop down, so you could actually change it from this view. That may not happen frequently from a provider standpoint, but from a nursing standpoint in the ambulatory setting, if they're in this view already, looking at other pieces of the patient chart and updating things, then they'll be able to change or set the compliance. So if it, by default, if the patient comes in and there's nothing documented for compliance, they could go through and select it in the drop down for each of these. So that's something that's currently being worked on today. Okay, let me switch back to the PowerPoint. Talk about the next item. The next one was about being able to document med history within medication reconciliation. That one I would expect is something that would be more common in the ambulatory space rather than the inpatient setting. Sorry, I guess I should have kept the domain open, but within that home medications component that we were just looking at, we have released within MPages 6.13 the ability to do what we've sort of coined as a one-click reconciliation for the ambulatory setting. Up in the upper right-hand corner, there, once you enable it, there would be a link that says reconcile. Once you review the patient's home medication list, and if you needed to discontinue anything or renew anything, you're able to do it from within that home medications view. And then if there are no other changes that need to be made, you can just hit the reconcile link, and that will go through and assess from a meds rec standpoint and stamp out a complete meds rec without having to launch the full outpatient reconciliation window that you would be used to today. So we've added that to try to streamline the process from an ambulatory setting, so you don't have to launch that full view, especially if you have a fairly straightforward patient. You know, they're on a couple of meds, there aren't any changes. You know, they came in for something fairly straightforward, or you know, you really don't need to make any changes to those medications to be able to just say, okay, I'm done. I've reviewed this patient's medication list. It all looks appropriate. Hit the reconcile and be done with it at that point. If you have a complex patient, you can still launch that full outpatient reconciliation view and see everything from a left and right. And if you need to make several adjustments, be able to see it within that view, or if they have a lot of medications, but that would not be necessarily required every time that you're seeing a patient. The one-click reconciliation option will only be available for outpatient or ambulatory type encounters. So your inpatient setting, there would not be a risk where that button is available for them to use on the inpatient side, because we do want them to do a more thorough reconciliation on the inpatient side. So within the system, we'll flex when that option is available.
So for those on the call, is there anybody that's using that today, and any feedback on if this took care of our need?
Yeah, Francis, this is Paul Clark from Concord Hospital. I think one of the reasons this was important is that if in the outpatient setting, sometimes we have to proceed seeing a patient in which a med history has not been completed. And for the providers, we always use the med rec screen, at least that's what we train to, especially my cohort of patients, which are geriatrics. They all need medication reconciliations. But if the med history hasn't been done, it requires me to go to a different screen just to document history so it can start my med rec. So I think one of the asks was just be able to do that in the one location.
Okay, thank you, Dr. Clark. So I guess probably the most intrusive piece of it is the prompt that you're getting when you try to do reconciliation, and you're getting a prompt saying that the med history has not been done yet. Is that correct? Outside of that notification, are you able to perform the things that you need to within the reconciliation view? Because I guess I'm wondering if we primarily need to just look at trying to figure out how to suppress that notification in certain circumstances, whether it's, you know, flexing for the outpatient setting, you know, don't have that warning, for example, if that would provide limit some sort of that barrier there.
I don't know. So what I always do is I go in and document history and unstart it. So it just brings me to a different screen. I document history because I really do history at the time I'm doing my reconciliation. Mm-hmm. In the inpatient world, when I was doing that, I did the same thing. And if somebody had a good medication history done for you, that's great. But occasionally, that you would admit patients in which the med history wasn't done, and it was just easier for me to do it directly off the medication reconciliation screen. But it just requires going out to do a meaningless task just to so that the history is completed so you can start the process.
So what would happen, Dr. Clark, if you did the med reconciliation without doing the med history? What's the negative outcomes of that? Is there compliance issues, or is there?
I guess I didn't. Because I get the warning, I always go out and do the med history. Maybe I can ignore it.
And I think that's what Francis was leaning towards, is if that, you know, and as physicians, we all want to be, you know, we all want to do our duty, do our part. If we see an alert that says do med history, we want to do it. If there's a negative outcome, if there's some type of compliance or if there's some type of report that's coming out saying, this many patients didn't have med history, I think that's definitely a scenario we want to understand and follow through with. If it's just that, we have this alert that's coming up and asking us to go do something that maybe doesn't really have any consequence for not doing if you've done an appropriate meds reconciliation, then I think that's what Francis was leaning towards is saying, can we remove that interruptive alert?
That would work for me, but.
So maybe let's break it down by venue. Because I would assume on the ambulatory side, where it would be more common for a provider doing the med history while they're, discussing with the patient or doing the reconciliation, and that maybe in that setting, it would be okay to just remove it. On the inpatient side, I would maybe be a little bit more reluctant for that circumstance because we want to ensure that the provider is aware that no one has reviewed the home medication list. And if that patient has been seen within your organization before, there would be home medications previously documented that would kind of be that starting point. This is the best information that we have at this time. But we want to make sure that the provider's aware that no one's looked at it, today essentially, and reassessed that or reevaluated that for the patient to see if it's still accurate. And the inpatient side.
Totally agree with that. On the inpatient side, I think it's different. I would totally agree with that.
Do you think on the inpatient side, if there was a sort of like a bypass, maybe the intent of the notification was maybe it's a good intent, but maybe it's too strong of a like a block from a workflow standpoint? Do you think if we basically say, like, do you want to continue, yes or no type of scenario, would that be, what are your guys' thoughts on that from a risk standpoint, from providers just always saying, well, yes, I'm going to keep going. There's kind of the two sides of the coin, if they should, and like because they're going to add those medications themselves, those are definitely good situations.
I think that would be extremely helpful. I mean, some of the challenges we get is, we don't have pharmacy techs 24/7. And let's say a patient comes in for observation and, the doctor gets to do the discharge before we ever even got to really do a very thorough history. And so lots of times they're just bypassing that alert and going on in anyway. So I feel like a yes or no would be helpful. And I think the only other area for our facilities that have newborn nurseries, we had to really eliminate that alert for that encounter type because it's not applicable for them. And so it was stopping them every time before they did discharge medrec and really just causing a lot of frustration.
So if I'm hearing right, and if there's other feedback, please, would love to hear it. But if I'm hearing right, for the outpatient side, the alert is probably not needed. For the full inpatient visit, so 2 midnight plus full inpatient visit, we might consider changing it to a notification, hey, it's not done, the med history is not done, do you want to continue, yes, no? And then certain exception types, so maybe ambulatory only inpatient stays, such as observation or same-day surgeries, things like that, and newborns, maybe removing the alerts for those as well.
I'll say this, Paul Clark, and I would say on the ambulatory side, if the alert said med history wasn't done, do you want to proceed? Yes. I don't think that's bad. It's just I don't want to have to go to this other screen. I think it's probably important for people to realize the med history wasn't done. Maybe they know or don't know that when they enter that screen, but it forces them to at least make sure they're being a little bit more thorough with their medication reconciliation if nobody's actually confirmed the history.
So maybe
Yeah,
this. Go ahead.
was just gonna say that, yeah, that's a good point, and maybe having that consistent behavior across would make sense, and that message has value within it, but we just want to let them get past it, be aware of that information and be able to decide how to proceed from there.
So Francis, what I would say is that this group's very willing to give feedback. So, if you take the feedback from today and you all come up with some consideration, you want to either get on another call with us or email back out to the group, we're more than happy to chime in, as you consider enhancements related to that item.
Yeah, what I'm thinking.
That's great.
Yeah, what I'm thinking is maybe the wording of that interruptive alert could change to a yes, no. Do you want to continue? Yes, no. I would still agree with you, Dr. Halford, that the newborn probably doesn't need that alert at all since it's not relevant, not appropriate, but maybe just changing the wording. So, we can definitely look at that and see if that's an option.
Sounds great.
Francis, before you move on, sorry, before you move on from that one, what was that M-Page version that you referenced?
It was M-Page 6.13.
6.13. Thank you.
Yeah, no problem.
Hi, this is Khadil Yafi. Can I comment?
Yes, please.
Absolutely.
Okay. Thank you all. It's a nice discussion. This is Khadil Yafi, the CMIO from Sidra Medicine from Doha, Qatar. And thank you for inviting me to be part of this committee. So basically, from our side, how we are doing it, we give the responsibility for medication history taking for nursing. So the nursing, they are doing the history, and the doctors, they are doing reconciliations. And we are monitoring both. And also for outpatient and for inpatients, we put the hard stop. That means you cannot discharge or admit the patients without doing the medication reconciliations. This is because we want to improve the compliance for doing medication reconciliation for ADT, like an admission, discharge, or a transfer order. But what we face, there is a challenge that is about the quality of medication reconciliation. You're right, you can monitor about the medication history and reconciliations, but it's very hard to monitor the quality of medication reconciliations because the doctor, he can acknowledge. He can say, I acknowledge, I review all the medication, but maybe he didn't do it because we have some resistance, some group of doctors who they said, this medication is not belong to me. It had been ordered by other subspecialty. So I will not review them or edit them. I just acknowledge them and I will place other medication. And sometimes we face up by that the doctors acknowledge the medication reconciliation, but we see, like frequent orders or like multiple medications. So that means we know ahead that medication reconciliation was not done in a proper way, but it had been actually checked right. So do you face this problem? And because I'm still working with a physician to show them that it may consider, like risk on our patient, but we have this a minority that we observe. And I want to see also like your comment on this side.
Well, this is Paul Clark. I can just give you our approach to this at Concord Hospital. That acknowledge medications, we allow our specialists in the practices to use that, and we allow like the surgeons in day surgery to use it. But for hospital med rec and for primary care med rec, you cannot acknowledge. You have to go through the med rec and you have to do them each med. So that doesn't guarantee it's good quality because people can still flip through, but we don't allow the acknowledge all for in those settings.
Okay, thank you.
I'll just add, I think it's a good question. I think that quality is sometimes harder to define than quantity, of course. I think if you have certain scenarios where you know that the quality is not up to speed, you mentioned a few examples where there's multiple meds and things like that, targeting specific providers, which it sounds like you're doing, is a good way to try to do accomplish that increased quality. But yeah, it's a tough situation. I mean, I know that even for me, when before we had, the systems where I worked before there was electronic medical records, there was a paper handed to me and the nurse had essentially completed it and I signed off on it. So it seems like an additional burden sometimes. And so we get pushback, but I would say I would agree with you. I think it's a high priority when we're trying to increase the quality of the care our patients get and minimize medication errors. And so I think it's a good project that you have to improve the quality of that.
Thank you. I appreciate that comment. Thank you.
Thank you. Okay, we'll move on to the third bullet that we have on here around combining the home medication and inpatient order into a single radio button. And this would be specific within discharge reconciliation. Within transfer reconciliation, for example, we do have some of that combining logic. Having the single radio button is definitely something that we have heard from several organizations about wanting that to be fewer clicks, essentially, to be able to navigate through discharge reconciliation. The reason that we do not have those two, if the patient was taking lisinopril at home and it was continued on the inpatient side, the reason that we don't combine those two into a single radio button today is because there can be differences in the dose information between the inpatient dose versus what they were taking at home. There are some circumstances where you have to change the dose form on the inpatient side, whether that's some medications that there's like an IV to PO type of situation, or if they were taking an extended release at home and the inpatient side does not have an extended release and they have to use a standard release, those dosages may differ. So with some of those types of situations, we have not combined it into a single radio button. So we can allow better distinction of if you increase the dose on the inpatient side, do you want to continue on the inpatient dose or do you want them to continue on the home dose? In general, if you are wanting to keep them on what they came in on, then we would want you to continue the home medication dose, even if those two are the same, essentially. So we have introduced the continue home medications button and do not continue remaining orders as two button options at the bottom of discharge reconciliation and outpatient reconciliation that can be used to help reduce down the number of individual clicks that you need to make and some of that delineation between the two. So if it's a situation where you're primarily continuing all of the things that they came in on, you can just use the continue home medication button at the very bottom and then make a couple of exceptions from there. If there's continuing 4 out of the 5 home medication meds, for example, you could use that button to just make the change for the one medication and say, I want to continue the inpatient dose on this particular medication. And then all of your rest of the orders, you can say, okay, do not continue everything else. So those buttons were provided to help minimize some of that, the tediousness of the individual clicks around that, while still giving you the flexibility and ability to say, in this particular circumstance, I need to increase their dose from what they're taking at home and continue them on this particular dose. Some of the conversation may have been around therapeutic substitutions as well, where you're changing the medication on the inpatient side between two different, like a metoprolol and a atenolol. If you're making those switches on the inpatient side,
we should be able to add that.
If you sorry, go ahead. If you utilize,
somebody have a comment, question. All right, go ahead, Francis.
If you utilize the therapeutic substitution functionality that we have available that's doing that conversion, then the atenolol and metoprolol, those two will be sequenced together, even though alphabetically they would be separated. With the therapeutic substitution functionality, it would bring them together so they are next to each other within discharge reconciliation to help kind of show that relationship between the two. Beyond that, something that we've definitely heard a lot of feedback around and something that we've talked about on our side a lot is around the desire to be able to sequence the discharge reconciliation based off of therapeutic class. to be able to, see, am I sending them home on one beta blocker, or I'm sending them home on a beta blocker at all. I want to make sure that, those selections kind of have been made. And that is something that we do not have available today to be able to show the therapeutic class or allow you to do any sort of sorting within the discharge reconciliation view. But we have, over the past year, there's been other development that's been tied into it, but specifically with some development that we've been doing around the home medications component that I was just showing earlier. We've been doing a lot of work around being able to include external med history information from different data sources. So as we were doing that development, we were making a lot of changes to that view. So we thought it was a good opportunity to also introduce a therapeutic class concept and some sorting. So we thought that would be a place where it would be a little less impactful to try to introduce it in that setting versus trying to change up all of our meds rec windows if it wasn't quite meeting the mark, having to redo it all, and just how much it's utilized on a daily basis, and the importance of that function from a clinical and patient standpoint. We didn't want to try to interject this concept directly into that. So we've been using another area to try to introduce the therapeutic class concept and ability to sort by that. So that is just getting released to a couple of solution partners right now. So we're definitely going to stay close to that and get feedback around how that therapeutic class presentation is. Do the therapeutic class groupings make sense from a provider standpoint and the sorting of it? There's a couple of particular items that have been sort of challenging as we've talked about therapeutic class, is around certain medications being in more than one therapeutic class and trying to determine which grouping, when we're sorting it, should it fall into, and then also just some of the nomenclature, because we get the therapy classes from Multum, which is the very clinical therapeutic class name, and it is not always the more of the colloquial or how we typically refer to it. So from a nomenclature standpoint, that's something else that we kind of want to keep an eye on and definitely get feedback from providers as we start kind of testing out that capability to see if it's something that is adding value and is sort of meeting some of those expectations. And if it is, then we'll look to see how we can introduce that type of concept in other areas like meds rec and things like that.
Hey, Francis, we're all kind of at different places in our careers and different places in our relationship with Cerner. So if an item is out with solution partners for testing, how does that translate into a timeline for when it's generally available? Do you mind to just share that with the group?
Yeah, no problem. So I will say that it depends on the particular capability and what's sort of being tested right now. So the development that the therapeutic class piece of it is kind of rolled into with importing external records that come from CCDs, the portal or Healthy Life, and scripts. There's lots of things kind of wrapped up into that particular development. So I would expect that one will take longer through the validation process because there's a lot of other larger moving parts. And we've made updates, across medications, but also allergies, problems, and things like that. So that development specifically is just a much larger entity. Other things that are smaller pieces of functionality, we may be able to release to a solution partner that's sort of rapidly taking code as we're releasing new things. It may take maybe 6 to 9 months before that's generally available. If they're able to, move it to production fairly quickly, if it's all working well, then we'll roll it into the next SP release that comes out on a quarterly basis. So a little bit is dependent on the timing of things. If we're able to get it validated and then hit the cutoff for the next release. If not, then we have to sort of wait a quarter before it gets into that following release. So it does depend a little bit on some various factors, but but for the therapeutic class one in particular, will definitely be sometime next year before we would expect that to be generally available.
So Francis, this is Paul Clark again from Concord Hospital. I'm glad to hear there's some movement on therapeutic class, but it's functionality that we had to give up from our legacy systems. We've actually gone to an API to give us some visualizations of meds by class. It's causing danger every day because you do not have that functionality. So I think it's great you're making progress. It definitely needs to be available on the MedRec screen, duplicate anticoagulants, duplicate antiplatelet agents. They're just so many examples of bad events, and we can share some of our ideas with you again, but it's one of those things that, you know, if it's next year, I guess that's better than never, but it's a big gap, and we gave up that reconciliation with the legacy system where we had it almost 10 years ago. So it's just very frustrating from a patient safety perspective not having that functionality.
Thank you. Yes, I definitely understand the need for that within the reconciliation views. I guess the general availability of the therapeutic class that we introduced in that other area. And I think your points are valid in that, you know, having something more accelerated is definitely something that's needed. So it's something that we, you know, it's possible that we're able to get, you know, enough validation around how that capability is working without the rest of that, you know, functionality becoming GA, and just sort of focusing on that piece of it. And then look at, you know, if at that point we're able to kind of expand that use of it independent of, you know, that capability kind of being pushed out elsewhere. We definitely wanted to make sure that introducing it, we don't want to create, you know, more challenges by introducing the concept within, you know, MedRec, or it's not, you know, it's not providing the information that's needed. But yeah, we definitely need to kind of keep that, you know, top of mind and try to accelerate that as much as possible.
Hey, Francis, to Dr. Clark's point, I don't think we'll have time to do this today, but maybe you could send us some tips in email. But that's on that third bullet point. We did want to decrease the clicks, and we did want to talk about, you know, therapeutic substitutions, but the bigger thing was about safety, and it was the fact that even if it's the exact same medicine that we just converted into a hospital medicine, you can still continue both, or you could accidentally prescribe both. And so although we're not getting the answer we're asking for on the true MedRec screen, it's my understanding that your team has some ideas that we could either consider with rules or duplicate checking. And perhaps as a follow-up, you could just send us some additional information on how to mitigate those potential errors in discharge MedRec.
Okay, yeah.
Okay.
Hi,
And
Francis,
then,
this is,
go ahead.
sorry, this is Christy Wright from Northside Hospital. I do want to go back to some of your comments in the very beginning about not combining the home med and the inpatient med because there could be some differences. Like Concord, we came from a legacy system and lost this functionality, and our physicians have been very frustrated with this loss. There are plenty of times where it is the exact same med, dose, route, frequency. So I still think there's value in pursuing this. It is clicks, but it's also safety, because I think when you are looking at an overwhelming screen that has a lot of duplicity, it's a safety issue, not just a how many times do you have to click. And so in our legacy system, if there was a difference, it was listed twice. If it was the exact same, it was listed once. So I did just want to go back and revisit that again and say I still think that there's value in looking into this functionality for a number of reasons, and hope that Cerner would be open to looking at that again.
Okay, yeah, that's good feedback to hear that. that previously in your system, it would combine it in some cases, but not in others, and that was understood by providers, and didn't create confusion why sometimes it was combined together and sometimes it wasn't. But
yeah, and the other thing I'll say about the buttons at the bottom is, yes, they are designed to help with saving clicks, but there are a lot of folks who are afraid to use those buttons because they don't exactly know what they're going to get. They don't know what they might have missed. So when you do what you think you need to do, and then you're going to go hit a button that's a catch-all, if you miss something and then you discontinue it because you hit a discontinue everything else button, there's a lot of hesitation to using those buttons. And so if it's safer to go line by line and complete your med rec, they need fewer lines.
Hey, this is Miguel. So, the idea of having a system with it is one radio button and moving to a new system, and I'm not doubting any of the things that you're saying, but sometimes it helps if we have quantitative data. I don't know if anybody has data showing, the error rate or anything that would go to support this. I think that would help us in our discussions internally as well to say, hey, look, this is a safer way and we've got data to show it.
I think probably for each of us, we'd have to figure out how to run a query or do an additional report to say, how many times did you get the same med ordered twice or continued twice or continue and prescribed, in the specifically in discharge med rec.
No, and that's fair, and I understand it's a big ask, of course, but I was, in case somebody had data that would help those discussions, so understandable.
I will say what Christy brought to the table and Dr. Clark from Concord and then Covenant Health, you have, a number of hospitals with those three combined that all felt like this became a safety issue when implementing Cerner and continues to be a safety issue even a couple of years after a go live. And we all three came from very similar from legacy and the fact that those were combined.
Definitely. Yeah, I think that's, of course, weighs heavily on when we go and make decisions internally.
Yeah, we
Francis, I want to
make it would be old data, but we could dig out. Before we implemented therapeutic class, we had quite a few incidents of duplicate anticoagulants, and we did institute that, and we basically dropped that, to zero, but based on reporting, kind of quality reporting. But that'd be kind of old data at this point, but it definitely reduced the chances of having dual anticoagulants, dual beta blockers, that type of stuff.
Sure. I want to make sure we get through these last two as well. So is it okay if we move on to the next one?
Yes.
Okay.
Okay, I'll try to go through these fast because I know we don't really have very much time. But the next one was around being able to access the chart while you're doing medication reconciliation. Wanted to, where did my pair chart go? Okay. To say that, first of all, we definitely acknowledge the need to be able to, no, that's pulling up. It's pulling up the wrong part of pair chart. Or it's not pair chart, it's just of the domain. Okay, I might just have to talk through it, but the ability to access the rest of the chart, we definitely know is a challenge within medication reconciliation, and something that in the future we would like to try to make it so MedsRec is not a separate pop-up window, which is essentially what's restricting you from being able to review the rest of the chart. And that's something that we are trying to work towards, but it's not something that we can make as a quick and easy change because of the way that everything's sort of just coded right now. We would have to rewrite all of medication reconciliation. But going forward, that's definitely the intent, to be able to access other places of the chart. I was trying to show within MedsRec that we have a side panel that pops out that gives you access to some information. It's not it's not comprehensive of being able to see the MAR or documents like previous, like progress notes and things like that. Any of those physician documents you're not able to access from here. But we do have a medication history snapshot that's available. So if you're in the clinic setting and you want to review previous versions of the patient's home medication list, you can go through the medication history snapshot. And looks like the domain's like not catching up with Teams. And then there's also related results and problems and diagnoses as kind of sub tabs within that view. So you're able to get to that within discharge or any of the reconciliation windows. We also have reconcile and plan, so you can plan it and then come back to MedsRec once you have reviewed other places of the chart that's needed. Again, definitely acknowledge that that's not optimal to try to save everything, close out, go look for things, and then come back. So that's definitely where we're trying to get to. But I just wanted to share that those were some of the things that we have available today within the reconciliation window. And then the last topic was around being able to continue continuous infusions within discharge reconciliation. That one I know there's a lot of sort of challenges around the workflow today when you're sending a patient home on infusions, where we have the ability to continue some infusions but not the continuous infusions. We have cross encounter reconciliation available that's intended to be utilized when you're transferring or discharging them to a SNF, behavioral health, or another facility. It could be in or outside of your organization. It could be like a nursing home that's outside of your organization. You're still able to use that particular window. Within that cross encounter reconciliation, it does allow you to continue continuous infusions there, and it's provided on a printout. If they're sending the patient to an outside facility, that printout can be used and would include all the details of that continuous infusion. And then if it's within your organization, it would provide that as proposals on that next encounter that they can accept with those same details on the following encounter as part of that process.
Great. I know we were down to the last 3 minutes. Is there anything that the group wants to talk about from a meds rec perspective? I know we had our top 5, but we also had an additional 7 that were on that list. So I know we don't have time to go through those, but anything else we wanted to chat about?
Hey, Brian, this is Christy. One thing I'll just comment about that 7 is there are some things that have started to grow in their importance on the 7. So it would be great if we could have Cerner reply again, maybe with some updated responses, especially the one about resetting a discharge med rec so the patient doesn't really go home. And you actually don't have a good way to reset. You can clear the buttons, but it's not a true reset of the med rec. So some of the ones of the 7 down below are starting to creep up to be a little bit more important than they were. So it'd be great to just get a little feedback there, and maybe just in writing from Cerner.
Sure, we can do that.
Hey, this is Grace Wu from Murray Regional again. For those of us who weren't present when the original conversation was had, can we see what the other priority items were?
Yeah, Grace, it was on the last email that I sent. I believe it was on Monday. I had both an agenda and there's also the meds rec list on there. If you scroll down, those remaining ones are on there. I can resend it to you though. just to make sure that you have the very latest copy.
Yeah, that would be great. Thank you so much.
Okay, yep.
Just for the group right now, I added those to a slide as well. I know we don't have time to talk through each of those, but I think it was Christy that had just made the comment around needing to be able to reset the reconciliation. Actually, it looks like I think I might have missed. Sorry, I actually missed that one on our list as I was sort of transcribing it. But on that particular one, I guess, is a situation where the patient was supposed to go home and certain medications, their home medications were stopped, and then there was a change and you want to continue those medications that the patient was taking at home. And if so, like, I guess, how can you give me an idea of how common that is?
That is a real scenario, absolutely. And so you can't get those home medications back very easily. So I think that is a scenario. Another scenario, in addition to the patient not being able to go home, is that physicians get called away. And if you have a really sick patient with a lot of meds, physicians in the middle of doing med rec and they get called away, a lot of times they would like to just start over, because when you can't see the home med that you might have discontinued anymore and you come back, you're doing a med rec with partial information. And so that's a significant patient safety concern when trying to discharge a complicated patient with a lot of meds.
Okay, thanks.
Sure.
I don't know if, so that scenario in general is good for feedback for us to think about more, to see if there's other things that can be done to improve that overall process. But I did just want to mention, as you were talking about it, that made me think of something that we just released in the January release within Reconcile and Plan for discharge reconciliation. So that can be utilized if you get pulled away, as you mentioned, partway through. If you use the plan button, previously or before you have the January code release, the documented meds would be discontinued right away, even though you're using Reconcile and Plan. But we did make a change, so those documented meds would stay. So when you come back to that, you would still be able to see that documented med and make a change and decision there. So we did make that change to kind of try to help with that sort of that scenario that you described. But I definitely understand that there's potentially other circumstances as well. But I just wanted to mention that's something that we have recently made an improvement around.
Thank you.
Yep. Okay, sorry, I know that we're a couple minutes over time, so I will let folks go. We can end it there. Definitely appreciate everyone's time and being able to have this discussion with you guys and hear some of the pain points that you guys are still seeing, and good feedback for us on the Cerner side to take back.
Okay.
Thank you very much for coming together. Yep.
And
Yeah,
Brian,
I just wanted to reiterate a thank you on behalf of all of the CMIOs and leaders on our call. I know the Cerner team's put a lot of work into this over the past several months, and Dr. Kerschel, I appreciate the open invitation for this group to be able to continue to collaborate with you.
Yeah, and I was going to say, Dr. Halford, too, if folks want to give feedback to Brian about what they heard and sort of the venue that this was placed in and how we can improve it next time, please let Brian know, and Brian can communicate that to us. But we also appreciate it too, the opportunity. Thank you all.
Thank you, everybody.
Thank you.
Just for those that are still left, we will have our next meeting August 5th. So I'll get an invite out for that, and we'll meet again then. Thanks, everybody. Have a good rest of the day. Bye.
Thank you all. Take care.
Thank you. Bye.
Thank you.